Hi, this is Judy Saalinger from Lasting Recovery, San Diego's premier outpatient alcohol and drug treatment center. And today we're talking about
So I'm going to zip through the data regarding buprenorphine maintenance treatment. Let me give you the bullet points, and then I'm going to flesh it out. One of the reasons I argue that BMT, buprenorphine maintenance treatment, is really a treatment that should be recommended to a lot of patients with opiate dependence is because there's a tremendous amount of data that it helps with some important outcomes. This is a simple slide. Remember the other slide where the decision making goes like this? Remember this slide. Small study, 2003, 40 subjects randomized to a week of detox and a year of medicine or counseling for a year. When you get here, you're back using again, okay? These are heroin users. These are people on buprenorphine who stay in treatment. These are people who get counseling who are now back on the street 50 days after they're randomized. Buprenorphine maintenance treatment keeps people in treatment. Does it keep everyone in treatment? Absolutely not. It just keeps more. By the way, the maintenance dose was 16 milligrams. So when you're talking to a patient about treatment options, remember this curve. Do you want them to be back in a week, in a month, in 2 months? Or do you want them to be back out? Next. This is methadone, by the way. I apologize for the abbreviation. 2,000, 154 people. A year of methadone, 6 months of gradual reduction. Maintenance medicine had better treatment retention, less heroin use, less HIV, fewer legal problems. Next. This is not buprenorphine. This is a great study. I'm going to just hit the high points. But if anybody wants it, this is 2014, 16 trials of buprenorphine maintenance. A lot of research. Huge numbers. You can read the New York Times and tell me about this and that anecdote, okay, which is fantastic and fine. But when you do a big randomized controlled study, and they've done a lot of them and find significant evidence, we need to weigh that higher than an anecdote about a bad outcome, as people informed by reason, I think. High level of evidence, positive impact on treatment retention. You guys want to do your jobs and want everybody else to do their jobs? They got to come back. And illicit opiate use. And adequate dosing is important. And it's equivalent to methadone and has some advantages. And methadone is really good for these outcomes. And BMT, buprenorphine, has fewer adverse effects. Next, 225 patients, low-dose methadone, high-dose methadone, 8 milligrams of buprenorphine maintenance. The most successful group. Here's why, folks. I treat people with buprenorphine lasting recovery. They don't do well. You know what? 20% one-year retention in these studies. Those are the numbers we're working with. 20% versus 0. We're not looking at 80%. So no matter what you do, there's going to be a lot of failures. So failure is not an indication that it's not a good treatment. Failure is an indication. How many patients, Wendy, do we treat with lithium to get a good outcome? A bunch. Some get this miraculous outcome. A lot don't. These are not spectacular. The best group, 1 out of 5 made it. Paid to be in the study for treatment. Next. 736 patients. When we tell an anecdote, let's remember this. Different doses, 1, 4, 8, and 16 milligrams of BMT. Dose-related success. As you were on a higher dose, there was a higher likelihood of staying in treatment 16 weeks out. Higher doses make a difference. Next. 220 patients, big study. High-dose BMT, high-dose methadone, low-dose methadone. High-dose buprenorphine was similar to high-dose BMT. Again, high-dose buprenorphine, 16 to 32, was better than low-dose methadone. Next. And then, sadly, and again, I believe in psychosocial treatment. Medication for opiate dependence, at least in terms of these outcomes, is better than psychosocial treatment. If you're going to do one or the other, the medicine is more likely to keep people in treatment and reduce illicit opiate use. Of course, we should recommend both, but that data is out there. Next. Let's just skip that. That's just one of the studies. And let's go ahead and look at this one. People should know about this. Study of 163 patients. This is buprenorphine rods, implants. Not out yet. The FDA put the hand up. Significantly more patients with the implants completed the study, 65% in this study versus 30% with oral buprenorphine. Next. They had a clinical global impression was better. Next. 23% were very much improved. Next slide. So this is a study, again, just reinforcing the point. They took 600 patients. They gave them a try of tapering off buprenorphine. If they failed phase 1, which 94% failed to stay sober with a simple detox, 94%, then they put them on prolonged buprenorphine, 8 weeks, and then tapered off, and 50% were successful during the second phase. Counseling didn't make a difference. Medication treatment did. Next slide. I'm not inveighing against counseling. And higher doses are associated with better attention, 16 to 32. I use 8 as my bottom floor, but this is just what the data that's out there. Above 32, no additional efficacy. Next. Abuse. This has less of a potential for abuse than buprenorphine alone or heroin, but it can be abused. It's a partial agonist. It's a side effect of treatment. Next. 8 milligrams can sell for $30 to $40 on the street if you want to know the price. Next. Half of people seeking treatment have used illicit buprenorphine. But if you ask them why next, it's not because I had an array of options on the table and I chose this one. It's because I wanted to manage withdrawal symptoms. Now, is that a good thing that that's out there for them to use to manage withdrawal? You know, we can debate about that. That's one of the side effects of treatment, is then why we should, do all these regulations and all these things. Okay, this is yet another study showing that a 1 week and a 2 week and a 4 week taper. These are people on the East Coast addicted to oral opiates. And how do they get retained in treatment? And the 1 week and the 2 week tapers are back using again. And the 4 week taper was better. So again, this is a taper study and not a maintenance study. But a longer taper is always better. Next. Briefly about our study. This is our neighborhood. Fred Rogers, very briefly, I'm going to flip through these just so you guys know what Suboxone prescribers in our community believe, and then we're going to have some time for questions. So we surveyed, this is an anonymous internet survey of beliefs, preferences, and practices. So people in our community, only about, if this is about the 50% mark, about half, a little more than half, were influenced by 12-step model of addiction. Half the prescribers. Next. Addiction is a brain disease. Most prescribers bought that. Prescribers. Next. These are percentages again. Addiction has a spiritual aspect. Less than half thought that was true. Excuse me, 20 and 20 is 40. So less than half endorsed this statement. Just to give you a sense of what people writing for this medicine believe. Next. Their goal was to eventually get the patient off buprenorphine. Only 10% said that was their goal every time, which is good, I think, because that shows that they're, and so the getting patients off buprenorphine is not every prescriber's goal all the time. Next. Average duration of treatment, long, 6 months, greater than 1 year. 2/3 of prescribers said their average duration of treatment is 6 months to a year. Okay, so most people in the community are not doing a rapid detox. Next. Average dose, if you think about this data-wise, I just told you that 16 to 32 has the best treatment, and 4 to 12 is what most people do. Now again, study populations are different than populations in the community, but it's just interesting to contrast what the research says with what the people are doing. Next. They said that buprenorphine frequently helps patients with depression, frequently helps with sleep, anxiety, and headaches. This isn't frequent, but this is. Interesting, mood symptoms. Next. And most people thought that it helps them regain function. Next. These are prescribers again. And then not a lot thought that abuse and diversion were significant issues in the community. Slightly true. And then this is an interesting topic I want to throw out there as a first start of a question. Someone who's on buprenorphine and functioning well is in recovery. Most providers thought that was true, but some didn't. Interesting. Next. Negative stigma in the recovery community. Yeah, about 50% said yeah. Negative stigma in the recovery community. Next. Stopping treatment. This is my last point. Chronic conditions need long-term treatment. Premature cessation of treatment usually results in relapse. Again, this is talking about heroin. Consider ending treatment. When do we stop? When there's no illicit drug use for months or years. And I tell patients it's when you have a life, which takes a long time to get. You've got social network, you've got medical and your mental health conditions are stable. You have a life that doesn't revolve around. That takes a while. That's the rock, right? Pushing this rock up. Here's Sisyphus at the office. Hey, Sisyphus, when you got a minute, I'd like to discuss this progress report with you, right? Next slide. Okay, so just to summarize where we've been, and then we'll take some questions. So we briefly talked about the opiates and looked at the fact that as a species, we've struggled with these compounds for a long time. Next. So again, remember we looked at the opiates in the brain and the emotional centers, and we talked about the history of how we got here. Next. We talked a little bit about the history of treatment going back to Grover Cleveland's day and the collateral damage phenomenon, the role of MDs in this. Next. And then we talked about kind of quote-unquote solutions and the history of buprenorphine in the context of opiate-dependent treatment, some basics of buprenorphine, and the data regarding treatment retention, dosing, and other things about buprenorphine. I want to thank everybody for your rapt attention. Part of our, I know Judy and Art and my goal with bringing everybody here today was to get some people's sense of what do you find in the community and what are people seeing and what are your thoughts about what I said or buprenorphine or...